I'd like to move on to our first session of the day. It's appropriate here this morning, preparing for the inevitable kidney care during a disaster, lessons learned. So we'll see what Helen has in store for us over the next couple of days. But as a former senior advisor to the U.S. Department of Homeland Security in the Office of Personnel Management, and as a Californian who faces unpredictable wildfires and earthquakes annually, I understand the real risk of both unnatural and natural disasters. This is a topic that is so important but often overlooked, as many people, whether kidney patients or not, often think this scenario will never happen to me. But I'm here to tell you that emergencies and disasters can strike at any moment. And it's important for patients, care partners, and families to have a plan in place. In addition to dialysis patients, we should feel confident in asking our facility what emergency preparedness plan and procedures they have developed to keep us safe and supported throughout an emergency situation. This topic is timely not only because of the topic, but also in recognition of September being National Emergency Preparedness Month. In 2023, AAKP expanded its emergency preparedness resources to support kidney patients, care partners, and families in planning for natural and unnatural disasters through the stand-up of comprehensive emergency preparedness web pages accessible through AAKP's national website, which includes top tips for readiness, various checklists, and necessary items kidney patients must have in personal emergency kits. Also available are links to resources within our federal and non-federal partners, including Health Care Ready and Kidney Community Emergency Response. To further our efforts, in June of this year, National Safety Month, AAKP rolled out a year-long safety awareness and public education campaign titled Every Patient Safe. This multifaceted campaign focuses on the unique risks and unmet safety needs of America's highly vulnerable kidney patients and kidney transplant recipients. Those include ongoing susceptibility to serious COVID infection and premature death, increased vulnerability to healthcare-acquired infections, and catheter-related bloodstream infections among hemodialysis patients, future pandemics, and disruptions caused by sudden natural and unnatural disasters. Many of these topics you'll hear about over the next couple of days, but for today's session, we will focus on emergency situations and learn from our two esteemed speakers, Helen Rose, Executive Director of Health Services Advocacy Group, ESRD Network 7, who also joins us as a representative of the Kidney Community Emergency Response, and Lynne Drawdy, Executive Director of Central Florida's Disaster Medical Coalition. I'd like to welcome Ms. Rose to her presentation. Helen Rose.
Take that down a little bit. Well, welcome everyone. Thank you so much for having me today. Can I get maybe a show of hands of who's in the audience really quickly? So any dialysis patients in the house? I see you. Any transplant patients? Yay. Home dialysis. Okay. Dialysis facility staff. Yay, see you back there. Physicians, awesome. And then family members, caregivers, friends, here to learn, yay. Okay, great. So as I was nicely introduced, my name is Helen Rose, and I am the Executive Director with ESRD Network 7, which is located here in Florida. Does anyone know what the ESRD networks do? Anyone familiar with them? Spoke to someone in their network previously? I see one hand in the back. Okay, great. I actually work for HSAG. We have 5 network contracts at this time, so I cover 12 states, including the Pacific Territories. So we are very well-versed. I've been with the network 14 years, and I was trying to get a count of the number of disasters we've responded to, and it's somewhere in the 20 to 30 range with the number of storms. We now cover Louisiana, and like I said, the Pacific Islands. But the role of the ESRD network goes way beyond emergency preparedness. We do a number of contract items for the Centers for Medicare and Medicaid Services. We do a lot of quality improvement with dialysis facilities. Our main role is to help and improve the life of patients once they get into dialysis. We don't do a lot of CKD work. We're mostly in the end-stage renal disease world, and we work with all of the dialysis facilities that are CMS accredited or approved, certified in our different states. I cover 12 states now. And so we do a lot of quality improvement. We do patient education. We do patient grievances. So if you have concerns about your dialysis facility, we have a 1-800 number you can call. We do a lot of data analysis. And we really, again, are trying to improve the care that's provided out there in the dialysis community. And then KCER, the Kidney Community Emergency Response Program, we have, HSAG also has that contract, and so that's more of a national contract that coordinates emergency preparedness across all of the large dialysis organizations and then feeds that information up directly to CMS. So I have a CMS contact, but then that goes beyond, and I'll show you a little bit about that reporting for a better understanding. So a little bit of difference between the networks and KCER for emergency preparedness is we work directly with the facilities. So as we have Helen entering the Gulf today, we have reached out to all of our independent facilities, especially along the coast, but throughout Florida, to make sure those folks are ready. We then work with the large dialysis organizations to make sure as organizations they're ready. We actually have a KCER call later this afternoon to see where things are being staged and to make sure everyone is ready for this big storm. So we're more at that direct level, and then we report that information up to KCER, and KCER coordinates that at a national level. So obviously this storm is not just going to impact Florida, it's going to go on to impact other states. So they'll coordinate with those other networks to make sure there's a real national effort to be prepared and then respond. This is our reporting process, and so we tried to explain this to folks outside of the dialysis world, especially maybe the EOCs and the folks who work at the state level, but also our dialysis partners, to understand that the information they provide is essential for response and recovery at the federal level. So it goes from us to KCER up to CMS ePro, which is their emergency response, and they're already having their morning calls, and then it goes to ASPR and HHS up the next level, and then up to FEMA. So FEMA has a good idea of what the needs are, if there are specific things that they need to bring into the area. So it's really important that all of the community and stakeholders work together. So this is a little older map. There is now a 2004 map that is out there. I think at this point in 2004, we're up to, there already have been $20 billion events. But this map just gives us a little idea, even back to 2023, the cost that emergencies have, not just to dialysis in the dialysis world, but overall. These are events that actually, each event was a $1 billion event. And it gives you a little idea, depending on where you are. I know this is a national summit. I'm sure some of you are local, maybe from out of town, but there's not really an area, except maybe that Midwest area, that wasn't impacted by $1 million event last year. And just really important, especially as kidney patients, to be considering where you are. I'm going to talk a little bit about risk and doing your own little risk assessment for your needs. This is a national risk index map. This is actually FEMA's map, and so what they've done is you can see the legend on the right-hand side from very high to insufficient data, but to very low. And you can see, as we're talking about Hurricane Helene, or soon to be Hurricane Helene, that the area of Florida, most of the coast, is in that very high index. You can see it goes all the way through to Houston, and then the west coast of California up through the east coast. Again, that more of a blue area in that Midwest, but we know that there are still things that can impact dialysis patients and the need for dialysis. Even if, in general, you're not getting big events, there could be things just in your town and power outages, things like that to consider. So just a few items. Again, as we're talking about risk and what is your risk, I live a block from open water today. So I know my risk as we're planning. We always have sandbags. We're always ready to evacuate, those kind of things. I think sometimes over the years we've been really working with dialysis facilities to help patients get more in tune to what's a risk for them. A few years ago, in Miami, there was a big event at the Hard Rock Center, and they had to close city streets, and one of the dialysis clinics is right next to the Hard Rock Center. So even an event like that, they had to close for a day. So as a patient, how does that impact you? So just kind of be thinking of those things. We're trying to get dialysis facilities do a risk assessment or a hazard vulnerability assessment, but things sometimes you don't really think about that can impact care. In 2022, we had a rural area that had a snowstorm like they had never seen before, impacted two facilities that were actually on reservation, and they had not really planned or prepared what they were going to do for backup transportation because they never had a storm like that before. So just an example of trying to be mindful of the things that could impact care. I think most folks are familiar with the wildfires in Maui and the 2 dialysis clinics that were heavily impacted from there, not just at the community level, but those folks actually had to be moved out of the area and sheltered out of the area to get dialysis out of the area. And so this was a big event. However, it was a fast happening event. It came on very quickly. And that can happen, as we know, in dry areas all over the country in the summer months. Wildfires can start up quickly. So if you live in an area prone to that, much of like California, do you have a plan? Are you thinking about what you might do if you need to evacuate? And last but not least, Hurricane Ian. I can't stress enough, if you work in a dialysis clinic or you know a dialysis patient, you're on dialysis, how important it is to evacuate. We have a new handout that we use to try to educate folks as much as possible. We know it's tough. It's not an easy thing to happen, but if this storm told us anything, it is you have to run from water and not to get stuck on a barrier island when you need dialysis. And so we try to drive that home with as many folks as we can. Not a happy thing to think about, but it is reality. The ESRD networks and CMS have been doing a lot of work over the last few years with health equity. Anyone familiar with that term? Understand that term? Probably using it in your work. Okay. And so when we look at emergency preparedness from a health equity lens, which we're looking at most of our work now as from a health equity lens, you can see that, and we know in general, the big things, right, when there's not even an emergency happening that are a big deal for dialysis: transportation, power outages, water, and communication. During Ian, that was one of the biggest problems also with one of the Hurricane Michael that landed in the Panhandle. There was no cell phone coverage during Michael at all. There was no way, even in the early hours of Ian, there was no way to communicate. Folks had to leave the area to communicate. So we know these things in general are a challenge, but during and after a major event, they become a bigger issue. The other piece of that is, if you live in an area that doesn't have a lot of services or maybe doesn't have a lot of grocery stores or the things that some of us might take for granted, this becomes exponentially bigger problem for these folks. And how do we start to look at that and address it? I think so. If you're a social worker in a dialysis clinic, it's just your routine thing. You're always trying to find resources. But as a bigger community, as a state, as a county, we really need to be looking at folks who are in more vulnerable areas and how we help them both prepare but also recover. So we talk to dialysis clinics a lot about who are your most vulnerable folks, who maybe doesn't really get that they need to have a plan as much, who rides public transportation the most, and really focus in with those folks on what their needs are going to be, both maybe storm or if there was an emergency event. How can you help them before something happens, but also, what are the resources that you could assist them with post? We'll continue to talk about health equity as a strategic priority. We really want to look, again, I can't drive home more, the disproportionate burden that folks experience. We both know we all know in certain neighborhoods, even after Ian, resources came to different neighborhoods at different times and somewhat delayed in areas. So really trying to address those needs. We all know where the socioeconomic problems are is where we really need to focus the most. And then the recovery. We know that families after the Maui fires that were living in poverty at poverty or below poverty are having the hardest time recovering, also because of housing and transportation options and recovery of property, things like that. And so all things to consider, both if you're a patient for planning, but also if you're working with patients that need to plan. Okay, so we'll get to the meat of the things we need to do. I, as the executive director, try to be more direct about things. Our handouts and things are not super flowery. We are trying to drive a message, and so that's the same thing I tried to do with our slides today, and things we've learned over the years. And I put it at the bottom, but it really should be at the top. If you are a dialysis patient or work in a dialysis clinic, more so for patients, talk to other patients. We really encourage folks you don't have to become a peer mentor or, have this big role, but talking to patients even in the waiting room about their plans, especially if it's someone you've been sitting with for a long time and maybe know that they've got some stressors, their phone isn't working one day, there's some different things, because while the social worker and the team is probably trying to help them as well, but I think hearing from a patient and kind of patients helping other patients to really understand how impactful this can be really goes a long way. We can't say enough about knowing your risk. Really be thinking about evacuation, sheltering, and your transportation. And these are all conversations that should be had with the dialysis clinic. We know that the larger dialysis organizations have very robust assistance and really big plans, but if you go to a smaller dialysis clinic or maybe an independent clinic that maybe doesn't have the same resources, you still need to be talking with them about what their plan is, so you know what you're going to have to take care of after the storm. Talk to other people, even if you don't live with someone. If you live by yourself, we really encourage patients to talk to someone, talk to a neighbor, talk to the neighbor about what their plans are. Maybe, depending on if their house is maybe different or newer, maybe you could shelter with them. I'm trying to think of all the options that you might have before you have to go to a shelter. Definitely conversations with the dialysis facility, and then knowing who to contact and how. Sometimes facilities give patients like this list and there's like all these 1-800 numbers on it. This is who to call. We encourage them to just make sure they have a cell phone number for someone at the clinic if the phone goes down, and then from there use the 1-800 number for DaVita or for Cineas, and then they can also use our 1-800 number at the network. We usually activate at 24/7 once an event is starting and then until the event ends, but we really want the patient to be able to get to the facility as soon as possible, because we know, so for Helen, for example, most clinics will close tomorrow and then maybe a delayed opening on Friday, depending on the impact. But what time on Friday? No one knows. You know, as a facility manager, you're not going to know that, but how are you going to make sure patients can get in touch with you if they have questions? Now, if they're educated and they understand and they have paper in front of them that says you're going to call them by noon to come in the afternoon, that may be helpful. Also talking to their families. We had a number of calls during Ian of folks who they didn't talk to the patient's family and the patient didn't remember what the facility said. So making sure you're talking to everyone. Many times a facility doesn't think they're going to close long-term, but they end up just because they maybe don't have a generator hookup and the power isn't on and they're closing. I mean, to us, a long-term closure is anything after 3 days. So where would patients go? What is the backup plan? Or if a patient is thinking about evacuating, where are you thinking about evacuating? I think what we learned with Ian as well is you don't have to go too far. You can stay, you don't have to leave the state. You can maybe even for Helen, come to Orlando, maybe come to the East Coast without going back. And how do we get you dialysis where you land? Again, all that information provided by the facility is essential for the patients. And then having patient addresses and phone numbers, you think that's like a simple thing that people should have, that patients would provide, but many patients move and never think to tell their dialysis facility. And so when we send folks out to start looking for them, we don't know where they are because we don't have correct information. So that's essential. If you haven't updated that with your dialysis facility, you absolutely should soon. I think we've talked about emergency supplies. I will say you don't really have to go too much farther than AAKP's website. It's very well done. Everything, it's straight and to the point, everything you need there, but I'll have some other resources that patients and staff can use. You know, it's really important, a go bag. We have a video of one of our patients that lives on the east coast of Florida creating his box, and so we just didn't have it posted somewhere, so I need to get that posted, but we're happy to send that out for patients, that because you can actually see him and what he does with the means that he has, and it's really good. But understanding having the go kit, again, especially if you live in an area maybe that's prone to wildfires or things that can happen quickly, that go bag needs to be packed and ready to go whenever. Again, we can't stress enough evacuations. We now have why dialysis patients need to follow evacuation orders, and that is primarily because you don't want to get stuck somewhere where you can't get dialysis. That's our primary. Our goal, KCER's goal, CMS's goal, ASPR's goal, is to make sure patients have access to care. And so the more we can talk about, you know, what are your possibilities for evacuation? Do you need to go to a shelter? What can we do to make sure you're somewhere where we can get you care after the fact is our utmost priority. We also need to know that we have household members as well as pets that we have to make sure we take care of. Not every shelter is pet friendly. Again, this is why we keep going back to talk to your friends, talk to your families, talk to your clinic about what your needs are, and don't forget your pets. Again, we've talked about transportation, sheltering. Shelters really should be used as a last resort. If you've ever gone to a shelter, you understand why, but they're set up with really small spaces. You're allotted your space. If it gets to full capacity, many counties have special shelters or special needs shelters. The state of Florida sent out their link to get signed up for that. You can do that at a state level here in Florida. But many, I also work in Louisiana, they don't do special needs sheltering. They do other programs within their shelters for folks who have special needs, but it's a different thing. So depending on what your state has and what your county or parish has, that's good information to know. Talk to your facility about it. Again, pets, big, important. Transportation is also important. If you didn't know this, once an emergency is activated, either at the state or the county level, all transportation goes under the EOC. So the usual minibus or HART bus or whatever your county door-to-door system is, that's no longer going to run the same. If there's rescheduling, that has to be done. So as a patient, you want to understand that and know what that's going to look like and be prepared. And many times dialysis facilities make other arrangements for transportation, even getting their own buses to pick patients up, maybe using Uber after a storm if possible, because that transportation is being diverted for other things. If a nursing home needs to be evacuated, different things that come up after a storm. So understand your transportation options. Just some good resources from our end. The good old emergency preparedness for patients. It's pretty simple. It comes in English and Spanish. The evacuation orders, really important. We encourage facilities to provide this to patients, especially if you know if patients live in like an AB, which you really should know at a facility level who's in an evacuation zone and really be talking about that. The KCER website has everything anyone would need. We've cut it down. It's some basic patient information, again, very similar to AAKP's. And then we have a really good checklist postcard that's on there, again, available in English and Spanish. Very simple to-go bag lists. Thank you. I'll just stay up here and then we'll talk.
Thank you very much, Helen. I appreciate that. I have a couple of sort of anecdotes there. When I live in Westlake Village, California, which we had an earthquake. I was out walking the dogs the other morning, and we had an earthquake that was 6 miles from my house, and it really gets your attention and gets you thinking about what you need to do. And about 2 years ago, there was a freak snowstorm in Big Bear, which is about 100 miles east of Los Angeles, and there were it was in San Bernardino County, fairly well off County, and certainly all the resources in Los Angeles County were available at some point. But there were people on dialysis stuck on the mountain who had just gotten away, and they had the routine, and the National Guard and the San Bernardino County Sheriff's Office had set up roadblocks at the base of the mountain to only let residents come in, and dialysis trucks were coming by to pick up dialysis patients to take them to the facilities, and they couldn't, first of all, they couldn't get through the checkpoints, and then once they got through the checkpoints, there was nowhere for them to go because nobody could get up the mountain. So somebody called me and said, what should we do? And I said, you know, how are people getting around? And they said, well, we're walking. And I said, well, send 4 people. So they got some National Guard folks to walk up and actually carry people down the mountain to get them to dialysis. But it's just, you know, it's simple things like that that can really, really create huge problems for folks. And we had a number of people reaching out to us today, and you saw the show of hands for how few dialysis patients are here today. And that's directly related to the storms that are coming in, because they have their routine, and just the fear of disrupting that routine and missing the second day or the third day or whatever. Because of the storm, we're encouraging the dialysis patients to make sure that they had an appropriate plan in place. So thank you for your timely presentation. And next, Lynne Drawdy is coming to talk about disaster medical coalition activities. Please welcome Lynne Drawdy to the stage.
Hi, I'm Lynne Drawdy, Executive Director of Central Florida Disaster Medical Coalition. But I'm actually here today representing all of the Florida healthcare coalitions and the coalitions across the country. Okay, so I'll talk a lot about what we do, but we are very similar to the coalitions that are across the nation. Every part of the nation has a healthcare coalition. It's one of the ASPR mandates. Our mission, and again, very similar to the others, is to develop and promote healthcare emergency preparedness and response capabilities in our region. We're the Central Florida region. We go from Daytona Beach in the north down the eastern seaboard through Metro Orlando and all the way down to just before Okeechobee. What we're trying to do, our vision, is to create and sustain a resilient community with a common purpose and voice, protecting and saving lives during disasters. And again, each healthcare coalition is unique, but we all have a very similar mission. We're funded by ASPR, the Hospital Preparedness Program, and it comes from the feds to the state of Florida Department of Health, and then in a contract to the coalitions. We support the local ESF8, which is the health and medical part of emergency management in Region 5. Our members are in our geographic area. Our core members are hospitals, emergency management, EMS, and public health. But we serve the entire healthcare community, including the dialysis community. I'm very happy to say that almost every dialysis center in our region is part of our coalition. The funding, again, comes through ASPR to us through a contract. It's allocated based on population, so we're a fairly big region, so we get just over $1 million a year. We meet contract deliverables based on the ASPR requirements and then receive reimbursement, usually in a multi-year contract. There are some funding restrictions. We can't pay for food, for clothing. We can't build things. We can't buy vehicles. We can't supplant, which means we can't pay for something that should be part of the everyday life of a community. We don't fund individual facilities. What we do for the common good. So if I do something for one dialysis facility, it must be for all of them. We follow the POETI model of FEMA, which is planning, organizing, equipping, training, and exercising. So most of our activities fall under one of those. Under planning, that's our resource page. It has all of our plans. We have a lot of regional plans. So we have a behavioral health plan, we have a response plan, we have a mass fatality plan, we have plans for individual types of disasters like infectious diseases, like Ebola, or chemical attacks or spills, or radiological issues, or whatever the type of event is, there's a plan for that. We also do a lot of individual facility plan templates to help organizations create their own plans. And I'm going to talk a little bit more about this under the training because we have something that really is a benefit to organizations like dialysis centers. Under organization, we are a not-for-profit. I have a board of directors that comprises the entire healthcare and response system, and I have a dialysis board member, Wayne Smith from DaVita, is on my board of directors, kind of being the voice for all of you. We have bi-monthly executive committee meetings and board meetings. I have quarterly member meetings where all of our agencies and special population groups are invited. We have monthly hospital calls. We have a lot of subject matter expert work groups to do planning. So, for example, we have a pediatric work group designed to look at the special needs of pediatric patients. We have an emerging infectious disease work group looking at things like COVID and Ebola. We also participate in county and regional emergency management meetings, the regional domestic security task force meetings, the urban area security initiative meetings. So all of the response meetings in our area we participate in. In equipment, all of our caches and equipment are listed on our website, which is there. We put a lot of our budget in preparing our hospitals. It is called the Hospital Preparedness Program, and that is the front line of defense in a healthcare emergency. We want our hospitals prepared and operational, so we spend a lot of money preparing them. All of the hospitals have a decon and emerging infectious disease package, so they have PPE and the equipment they need to respond. We have alternate care site and mass casualty incident caches across the region. So, for example, if you're in Daytona, at one of the hospitals, we have a cache so that we can stand up very quickly an alternate care site for 100 patients. We have an evacuation cache in the north, central, and south parts of the region, so that if a hospital or a nursing home or another facility needs evacuation, we have that equipment. We have an Ebola cache. We have the really scary-looking suits, the biosuits for people that are dealing with a highly infectious disease. We have portable morgues. I hate to say it, but that was our big moment we were on the national news a couple of years ago because we had to purchase portable morgues during the Delta surge, and it became national news, and we've loaned those out all over the place. We have a ventilator cache that we created during COVID because it got to the point where some of our hospitals were down to their last ventilator and didn't know what to do. Training, we do a lot of training for healthcare facilities, including dialysis, incident management training, how to create an incident command system, and how each position should operate. Not only do we do face-to-face training, we have videos for all of the incident management positions on the website. So if you're in a dialysis center and all of a sudden you are the planning section chief for your organization, you can go to our website and get a quick tutorial on what does that mean and what your duties are. We do a lot of hospital incident command system training. These are the next two that I really want to highlight for the dialysis centers. Most of you have a requirement to submit a CEMP, an emergency plan, to either your licensure or your accrediting body. We also have training and a software program. It's kind of like TurboTax for CEMPs. You go to the training, get software, you plug in your information, and it produces a plan that meets the requirements of the licensing agencies. We also have that for COOP, continuity of operations. And in a disaster, that plan is every bit as important as your emergency management plan. How quickly can you get back operational after a disaster? So both of those are available free of charge to dialysis centers. We do a lot of training for stress first aid, mental health first aid. Before the pandemic, and particularly after the pandemic, our healthcare system and workers are stressed and burnt out and just need as much support as they can get. We do fit testing training. We do an annual training needs assessment that's out right now to hear from all of our members. What training needs do you have so that we can include those? And then we post and share other trainings from other organizations. Exercises, again, this is something that we do that's a great benefit to organizations like dialysis centers. You have requirements about participating in community-based exercising, and doing those on your own is expensive and a little challenging. So we do 4 drills, one each quarter, that's a community-based drill that you can participate in from your facility and get full credit. The one that we just did in September was the active shooter drill. You register. We give you instructions on how to either create or improve your lockdown plan. The day of the disaster, we send an alert. You exercise at your facility, and then following it, you fill out a very brief survey, and we give you an after-action report that meets your licensure or accreditation needs. So we do 4 of those a year. January, tornado drill. April, we do a huge medical surge exercise with all of our hospitals, probably one of the biggest ones in the nation outside the military. Last year, we had 70 hospitals and 1,500 students going in as live victim volunteers to the hospitals. In May and June, we do an Operation Generate confidence drill, so we test your generators, and then September active shooter, and in December at our conference, we do a glass of mutual aid drill. It is where you get to actually reach out and test your mutual aid agreement. So if you've got an agreement with another facility, it's the time to just check, is that agreement still valid? Or do you still have the right contact information? Coalition staff response duties, there are only 2 of us, so we are not first responders by any means, but what we do is share situational awareness to our members. So for example, right now, I've put up a hurricane website, and it's got things like the curfew letter for healthcare staff so that they can get out and get to where they need to be. It's got the executive order. It's got resources like the ones that Helen sends out. So all of that gets posted. We have some systems in place. EM Resource is something that the hospitals and EMS use to tell which hospitals are open, which EDs are oversaturated, so that patients can get to where they need to be quickly. And there is a new product that Florida has just implemented that's going to be a game changer. It's called Pulsera. It is an electronic health record for patients that are in the EMS system, so that we can actually finally track patients in a mass casualty event. We do a lot of resource coordination. We have a lot of stuff, and if a facility needs something and their local emergency management doesn't have it available, they send a mission request to the state. We monitor all of those, and if we've got it, we can get it to you much, much quicker than the state can. And then we do support local EOCs. If it's a small local event, we may actually go and help staff the local EOC. All of our response assets are on the website. We have a few teams that really have deployed a lot in recent years. We have a regional medical assistance team. It's the only one left in the state. There used to be a state response system, and it went away. We kept our team. They deployed for 18 months during COVID in South Florida, doing testing and vaccinations for the state. We have a family reunification, family assistance center team. So if there is a disaster and the local jurisdiction isn't prepared to do family reunification or support families, we can send an experienced team in to get it up and running quickly until that local jurisdiction can take it over. We have a lot of disaster behavioral health responders. We have a trauma coordination plan so that if there's a large-scale trauma event, we can move patients to the right place quickly. And then we have a lot of caches. This is one area where most of the coalitions are a little bit different. Our expectations of our members are very, very minimal. We want you to participate. We want to hear your voice. We want you to all be focused on the common good and not just on individual needs. But we don't put a lot of requirements around our members. We don't say you must come to a certain number of meetings or participate in different things. The expectations are very minimal for members. For dialysis patients, again, our focus is on healthcare facilities, but where you can get involved is to join your local coalition and make your needs known. One of the things we consider in planning is the needs of special populations, and you are a special population for us. So we want to hear what your disaster needs are. On your table, there is a little map with all of the Florida coalitions and their contacts. So if you're in Florida, you can look at this and reach out and join your Florida coalition. I did check. There is still not a national registry of coalitions. I don't know why. ASPR can't provide that, but they can't. But if you are not in Florida, reach out to your state or local health department, and they will be able to connect you with your coalition. I promise you, just having your voice heard is really going to pay off in planning for your needs. So that's really all I have to share. Thank you so much for inviting me to be here today. I appreciate that opportunity.
Thank you. Thanks, Lynn, for a great presentation. After 9/11, Paul Conway, who's a prior president of the organization, and I were in government, and we were responsible for reviewing some of the continuity of operation, continuity of government plans, and we're actually struck by some were good, some were bad, but anyone who's in a facility, you have every right to ask for their COOP plan and see what they wanted, what they plan to do. And I'm going to open it up on the floor for questions, and I see Dr. Fadum surprisingly has one, so go ahead, Steve.
Hi, I'm Steve Fadum. I'm from Houston, Texas. I've been through probably about 10 major storms now. And a few things that we've learned along the way are, number one, many dialysis units still don't have generators that should have. And I think AAKP's major focus beside education is policy. And I think one of the things that we should do is work toward policy that dialysis units have a generator or have access to immediately getting a generator in the event that there's a power outage. We've had several problems where patients didn't get dialysis because their units didn't have a generator. They Ubered to the VA. I was on call at the VA, and they Ubered to the VA, and they kind of looked at me and said, where do I dialyze? My unit's out. We tried to call the unit. No one answered, and it was just, I don't want to use the term it was, but it was a mess. I guess that's another way to say. So the second thing is that I think a cheap trick is to get people to dialyze the day before. For example, if we're going to have a hurricane hit tomorrow, then call your dialysis unit and say, hey, I'm on schedule for tomorrow, but can I come in for maybe 3 hours or 2 hours today? And I think it should be part of the disaster plan to do this, but I think patient initiatives usually are better than disaster plans. So those are my 2 cents. Thank you very much for an excellent job.
Great idea. Thanks, Steve.
I would just add that we are seeing a change in the tide with that. I think from the previous events, more facilities are running, like today, they'll run till they have to close for patients that would normally be treated on Friday even. So just trying to get that done. Also the generator, there have definitely been some legislative attempts in other states as well as just at a national level. And we have seen if it's not going to be legislative, that even the dialysis companies are moving in that direction. Just recently we had a storm in Louisiana and more facilities had generators than ever before. A handful of Fresenius and DaVita facilities did not have generator and no generator hookup. So I think if it can't happen that way, it will happen by self-regulation to some degree, because you just really can't get open unless you have one.
Yeah, and I would encourage advocacy for that. Get it in statute. The nursing homes had some failures, and it's in statute now
Sure.
that they have to have generators, and that's the real safety net.
Absolutely. And Steve, I mean, I think that's an initiative that we can undertake. We can certainly approach the dialysis companies. They know who we are, and we can strongly suggest that they make that a requirement, and also the state government. So, well, thank you. All right. Well, thank you both for wonderful presentations. I appreciate you sharing your time with us. We have another question? Oh, okay. Sorry, the bright lights. Go ahead, Dale.
Hi, my name is Dale Rogers. I come from rural America, and I hear you guys talking about these things, and it works good, okay? It's not happening in rural America. And so how do we do things to make it happen in rural America, okay? I probably have more training than my county emergency response people do, but yet when I say something to them, they don't take me seriously because I'm just a patient. So how do we get the message out so that we're not being reactive all the time when these different things happen? I have a sister in Cheyenne, Wyoming, when they got that snowstorm. Her husband didn't get dialysis for days, and then finally he was able to get to dialysis on snowmobile. But how come we don't have these organizations reaching out to dialysis units to have them communicating with the county so these things are proactive instead of reactive all the time? And how can we move in that direction?
Again, every part of the country has a healthcare coalition. That's now a national requirement. So if you don't know who your healthcare coalition is, reach out to your county or state health department and they can connect you and get engaged, find out what their resources are, help them advocate for what they don't have.
Yep. Yeah, you're correct. When we see it all the time, I think, unfortunately, the dialysis clinics have to go to those folks, and if they don't have a lot of corporate leadership to help them do that, it's not happening like it probably should. So I would say the same thing. I think the facilities have to go to the EOC, and KCER actually has. We did this in a project a couple years ago. We have the materials to educate EOCs. We could even, I can talk to Keely and see what we can do, looking at that and looking at the areas, because their healthcare coalition can look a lot different than it does in Florida. But I think we have the materials to do it. It's just getting the clinics to actually advocate for themselves as well.
Part of the problem is, though, is in these smaller units in rural America, they don't have the manpower.
They don't have the manpower. Yep.
Yeah.
And so it gets put on the back burner. And so it just continually, it's reactive after reactive after reactive.
Yeah.
And that's what's got to stop. So we've got to find a method to
So many times it takes the hospitals getting involved, because the hospitals are going to see that surge. Even in a small rural hospital, you can't have dialysis patients sitting on your doorstep needing dialysis. Some hospitals don't even provide dialysis. So it could be that the hospital association can get involved as well to advocate to the EOCs, because they're part of all of the coalition work and they're highly motivated to work on that as well. So that might be an area to try to access as well.
And Dale, we could talk, because I'm sure we know people in the state that can at least reach down to the county folks and say, you know, what's going on here, and let's see your plan, and how do we make it better? Because it certainly is the expectation and it's the law, so there's no reason for it not to be, but it could just be attention. And
it is why the healthcare coalitions were created and funded federally. The EOCs in a disaster are really more focused on infrastructure, getting the power back on, getting the water system safe, getting the roads open, getting debris moved. We needed somebody focused on healthcare needs, and that's what the coalitions do.
we have one more.
Yes, Ed. Tony Faffel from Cormedics. I have two questions, and they have to deal with the disaster sort of prioritization of restoration of power. I know in New York, Con Edison, for example, after Hurricane Sandy, I experienced this in my neighborhood, in my block. They prioritized one patient who is getting home dialysis and other patients who have chronic illnesses to restore power to their homes first. And, the neighbors, of course, didn't mind that, they were bypassing the lines that could have restored power for the whole block to get emergency power restored to those homes that required it for medical reasons. I'm wondering if that program that Con Edison has in New York is ubiquitous throughout the country. If not, could one be put in, or could it be a template for that? My second question is dealing with medicines and device supply chains. Many times, if there's a Category 4 or 5 storm, as we know, like Sandy, like Katrina, sometimes services and supply chains are out for weeks. If the units are not well stocked, or the homes with increasing home dialysis are not well supplied, whether it's with hemo supplies or PD supplies, then there's a disruption of care. Are supply chains from the manufacturers essentially, and for those purchasing, adequately stocked up, especially in areas that are vulnerable for these disasters, coastal areas, for example, in Florida or Texas, or et cetera?
So what I would say about power restoration is no, it's not similar across the country. Even here in Florida, we've been told you can't turn on 1 or 2 houses on a street. You have to it's all set by area, and it's prioritized depending on the electric company and the region based on hospital location and outward. So hospitals are prioritized, but dialysis clinics aren't necessarily prioritized. That works differently in New Orleans. They're well aware of where every dialysis clinic is, and they worked in this last storm to get those blocks turned back on sooner, even if the families down the street didn't get their power. So it is very different. And to your point, there's been a lot of work by KCER to try to see if that is. It's because of the different electrical companies that haven't been sort of willing to do that, or depending on how their grid is set up to do that. So no, but definitely concern. And supply chain, from what we hear, and I can't speak for dialysis companies, but there are definitely storage facilities throughout the country where they have specific cities and specific states based on the needs, based on storms, wildfires, where they are keeping caches of supplies. Now, to your point, would that, if we have something really catastrophic that you couldn't get in, but we haven't seen where they were unable to do that yet. But if it's a big enough disaster, we could definitely see that. But I think that that's part of their planning.
Supply chain assessments and planning is a big priority for ASPR right now. We've seen so many failures over the last few years. The recent One Blood event was a big example of that. So that's going to be an area, again, where your voice could be heard, because there's going to be a lot of emphasis on that in the coming 2 or 3 years.
And
Great question.
in California, the electric companies or the power companies reached out to all of their customers and tried to identify people with medical issues and if you had some that relied on power, they issued generators, just straight off the top, and went around house to house and gave people generators. So they're taking steps, but one more?
Oh, my question, what I was going to say is, I live in the Tampa Bay area, Pinellas County, and I live on the same, my power is hooked up to the same grid as the fire station. So it does come on, it's one of the first early ones to come back on. Where I have a friend, they took like 3 or 4 days in 2004 after I think Charlie hit, or one of the hurricanes hit. It took them a long time to get their power back on, but mine came back on later in the day. So that's an
There
idea.
you go, live close to the fire station
Yeah.
or the hospital.
Police station or hospital.
Yeah.
Because they're going to get it on
They're-
back quicker
they're
because
prioritized.
they need these organizations to be operational.
Yeah.
All right. Well, thank you, ladies, both. It
everyone.
was a wonderful
you.
presentation.
For allowing us.
So I encourage each of you to visit AAKP's Emergency Response Preparedness webpage. And as I said, Paul Conway and I have quite a bit of experience going back too many years to really think about that really covers the basis for patients. And we've dealt with these issues up front, and visit the state plans here that we have, or the state web pages, because preparedness starts with all of you.